Hello, and welcome to the Endocrine Society's virtual ENDO 2021 news conference on heart health. My name is Colleen Williams, and I'm the Manager of Public Relations here at the Endocrine Society. Before we get started, I'd like to go over just a few housekeeping items to keep us all organized. Journalists may type their questions into the chat window at any point during the news conference, and they will be addressed during the Q&A at the end. Please be sure to include your name and affiliation with your questions. As a reminder, the press conference is being recorded. Recordings will be available on Endo Webcasting, the Endocrine Society's YouTube channel, as well as our website following the presentation. Today, we are very pleased to have with us Dr. Seda Gregorian of Michigan State University, Dr. Lisa Mullaney of Baylor College of Medicine in Houston, Dr. Anna Valentine of the Children's Hospital Colorado, and Dr. Jia Zhu of Boston Children's Hospital. Over the next 30 minutes, each speaker will present their findings and we will end with a Q&A session. I would now like to invite our first presenter, Dr. Gregorian, to speak.
Hi, my name is Seda Gregorian. I'm a third-year internal medicine resident at Michigan State University. And today I'm here to talk to you about rates of primary aldosteronism screening among high-risk populations. Next slide, please. So what is primary aldosteronism? So aldosterone is a hormone that's produced by the adrenal glands, the glands that sit on top of your kidneys, and they're responsible for regulating sodium, potassium, and water balance. So in a healthy individual, aldosterone is part of a mechanism that's aimed to restore physiological blood pressure in a situation where your blood pressure might be low, such as dehydration, in instances when you're excessively sweating, having diarrhea, vomiting, or blood loss. And what it does, it acts on the kidneys to try to retain salt and water, and it increases potassium excretion. So that's a mechanism in a healthy individual. However, when this mechanism is broken in an individual with primary aldosteronism, aldosterone is secreted excessively, and it's not dependent on a state of dehydration. So it causes persistently elevated blood pressure. And a lot of times in patients, we see low potassium in the presentation of this in a patient. And when untreated for a prolonged period of time, it can cause heart and kidney damage. Next slide, please. So why is this important? So 1 in 2 adults in the United States have elevated blood pressure. This is a pretty big number. And again, this includes, the majority of this is essential hypertension, but a portion of this is related to what's called secondary hypertension, and primary aldosteronism is the most common form of secondary endocrine hypertension that's estimated to affect 1 in 30 adults in America. That's about 10 million people. And as I said earlier, when it's untreated, primary aldosteronism does have higher cardiovascular and renal morbidity and mortality than the equivalent primary hypertension. And it can lead to heart attacks, heart failure, problems with heart rhythm such as atrial fibrillation, stroke, and eventually kidney disease or kidney failure. Next slide, please. So what are the screening guidelines for primary aldosteronism? So any one of the following 6 points can be a trigger for a physician to have the patient screened for primary aldosteronism, such as elevated blood pressure that's uncontrolled with 3 conventional antihypertensives or controlled with 4 or more, high blood pressure and low serum potassium, high blood pressure and an adrenal gland mass, high blood pressure and sleep apnea, high blood pressure and a family history of early onset elevated hypertension or stroke at a younger age, so younger than 40, and high blood pressure and a first-degree relative with primary aldosteronism. Next slide, please. So what we did in our study is we looked at an adult population with elevated blood pressure at MSU, Michigan State, outpatient clinics between 2010 and 2019 who met the criteria that I just went through on the last slide, the criteria for primary aldosteronism screening. And we wanted to look at the overall rates of screening for primary aldosteronism in this population. And additionally, we also looked at any patterns that might be associated with the screening, and that might vary, such as race, gender, age, and any comorbidities. Next slide, please. So what we found, out of 11,627 patients that had elevated blood pressure and were at risk for primary aldosteronism, only 3% were ever screened. So those that were screened were on average slightly younger, but the screening rates weren't any, we didn't see any dramatically greater screening rates in patients who were younger than 40 with hypertension. Screening rates were overall higher in Asian and Black populations in comparison to white Americans. And we also found that primary aldosteronism was suspected more often in patients with low potassium, as well as after complications such as stroke and kidney disease had already developed. And out of people at risk for primary hypertension or primary aldosteronism, screening was done more often in people who had adrenal nodules and least often with sleep apnea. Next slide. So really, despite the high prevalence and association with the cardiorenal morbidity, primary aldosteronism screening is only done in 3% of high-risk population. And it's typically suspected after the complications have already developed. And we really do need some more initiatives to encourage primary aldosteronism screening to prevent these complications from development in patients with hypertension. And thank you very much for listening. And I'd like to thank my PI who's here today, Dr. Adina Turco.
Thank you so much, Dr. Gregorian. I would now like to invite Dr. Mullaney to present their research.
Good morning. Today I will be sharing with you our findings that show that we can directly modulate heart tissue repair to stop the progression to heart failure. Next. And this is a remarkable finding considering that up until this point, we have done a good job in saving the lives of a patient after an acute heart attack. However, the damage to the heart is still there. And unfortunately, these patients have a high likelihood of progressing to heart failure. So even though there has been a progressive decline in immediate mortality following a heart attack, our next medical challenge is that heart failure after heart attack is now the leading cause of death in humans. And currently, there are no definitive therapies other than heart transplantation. And the simple reason for this is that we don't have any available therapeutics to stop the progression to heart failure. So after a heart attack, the damaged tissue scars, and this scar is very non-compliant. It's very stiff, and it severely limits cardiac function. And the progression of this scar eventually leads to death. And what we found, and what I'll be sharing with you, is that our drug, MCB613, acts on immune cells to prevent the scarring damage that leads to heart failure. Next. So our drug is an activator of steroid receptor coactivators. And steroid receptor coactivators act as transcriptional coactivators for nuclear receptors, as shown in the diagram on the left. SRCs 1, 2, and 3, there's 3 family members, bind to nuclear receptors and transcription factors in a complex to drive gene expression and ultimately protein expression, which controls cellular functions. SRC coactivators are widely expressed, and they function as master regulators for cellular changes and growth during both normal and abnormal tissue growth, including cellular responses to tissue injury. And previously, we and others have shown that SRC coactivators are expressed in the heart and they regulate cardiac functions, for example, cardiac muscle proliferation and responses to an enlarged heart, which is a feature of heart failure. Next. SRCs coactivate DNA-bound transcription factors in cell types that are critical for tissue damage responses after injury, including in the heart. For example, SRCs function in immune cells, endothelial cells, and cardiomyocytes, which are the muscle cells in the heart. Next. So we hypothesize that activation of these SRC functions by our small molecule activator would enable wound repair and preservation of cardiac function after an acute MI. Next. So we address this by testing our drug in a preclinical mouse model, whereby we inject our drug into the mouse, into the intraperitoneal cavity, 2 hours following permanent ligation of the left anterior descending coronary artery, which is simply a mouse model of myocardial infarction or a heart attack. We then measured ejection fraction, which is a measure of cardiac function, and what we found in the top right of the screen is that the black line in the mice that did not receive the drug, they have a progressive decline in cardiac function. However, the red line in the mice that received our drug, MCB613 attenuated both the early and progressive loss of cardiac function. And in the bottom right, these are representative histologic sections of our hearts where we look at the fibrosis in the heart, and it also measures the fibrotic scar. So in the top one, control-treated heart, you can see the presence of a large infarct and a large amount of fibrosis. However, in the drug-treated heart on the bottom, there's much less fibrosis, and the quantification for the fibrosis is in the bottom right. So MCB613 is preventing the damage after a heart attack that can lead to heart failure. Next, please. We then did single-cell transcriptional profiling for the purpose of identifying the cell types that were responsible for the improved healing after heart attack. And this is just an example of our single-cell sequencing profiling for the cardiac fibroblasts 24 hours after heart attack. And we're comparing the phenotypes of the fibroblasts in the drug-treated hearts compared to the control-treated hearts. So red indicates there's an increase in that cell type, and a blue indicates there's a decrease. So what this is telling us is that 24 hours after MI, there's an increase in the resident cardiac fibroblasts on the bottom and a decrease in the injury reactive or stress response fibroblasts. So taken together, all of our sequencing results indicated that the immune cells and fibroblasts were the primary cell types responsible for MCB613's cardioprotective effects. And on the right side, we also found that MCB613 reduces the inflammatory signaling in both heart macrophages and heart fibroblasts. Next, please. So taken together, MCB613 is directly modulating the immune cells. So the blue cells in the middle are macrophages, and our drug is decreasing the inflammatory signaling coming from these macrophages, and it's decreasing fibroblast activation. Next, please. However, we also found it's actually improving the wound healing response by enhancing the representation of reparative macrophages, and also on the far right, comp-positive fibroblasts, which are known to improve the structural integrity of the heart. So taken all together, all of these may limit cardiac tissue damage and the progression to heart failure. Next. So as I said in the beginning, survivors of heart attacks typically experience subsequent heart failure, which is now more lethal than all cancer combined. And our drug provides a great novel candidate to help solve this huge clinical problem of progression to heart failure. And as a final summary, our results demonstrate a novel approach to mitigate progression to heart failure by directly modulating the immune response to cardiac injury to prevent the progression of the fibrotic scar. Thank you, and I'll take questions during the final answer question session.
Thank you so much, Dr. Mullaney, for that great presentation. Next up, we have Dr. Valentine to go through their research.
Hi, I'm Dr. Anna Valentine, and I'm a pediatric endocrinology fellow at Children's Hospital Colorado at the University of Colorado. And today I'm going to share some of my research looking at cardiometabolic outcomes in youth with the diagnosis of gender dysphoria. Next slide. So let's start with some background. A 2019 survey showed that nearly 2% of US adolescents identify as transgender. And the term transgender refers to individuals whose gender identity differs from their sex assigned at birth. Some transgender people are diagnosed with gender dysphoria, which is a diagnosis used by behavioral health professionals to describe the psychological distress that results from the incongruence between one's sex assigned at birth and one's gender identity. And some people seek gender affirming interventions to align their body with their identity. And in the pediatric population, this can include one or more of these medical interventions in addition to other non-medical interventions. So these include puberty blockers, gender affirming hormone therapy, which may include estradiol or testosterone, and medications to manage menses or block testosterone. Professional medical associations, including WPATH or the World Professional Association for Transgender Health and the Endocrine Society, also note that gender-affirming hormone therapy is standard of care in adolescents with a confirmed diagnosis of gender dysphoria who wish to pursue hormone therapy. Next slide. So let's talk about what we already know about cardiometabolic outcomes in those with gender dysphoria. Most of our current data come from the adult literature, which shows that transgender women taking estradiol have increased levels of triglycerides and increased event rates with things like stroke, blood clots, and heart attacks. And transgender men taking testosterone also have dyslipidemia, including higher levels of triglycerides and LDL cholesterol and lower levels of HDL cholesterol. They also have higher BMIs, and when compared to cisgender women, increased rates of heart attack. Next slide. In pediatrics, at this time, most of our data are from small single center studies, and for the most part, they lack a control or comparison group. Additionally, the data are less consistent in their results, such as differing conclusions on BMI trends and changes in cholesterol concentrations. Next slide. So this study, which is a retrospective observational study, is a multi-center analysis that uses health information pulled from electronic health records from the PedsNet database. So PedsNet houses information from EHRs of many large pediatric centers in the United States, and we were able to pull EHR data from 6 of these centers listed here. The inclusion criteria for the study for the cases included a diagnosis of gender dysphoria listed within their medical record, and both cases and controls needed to have at least one outpatient visit because, as we know, times of stress such as a visit to the ER for an acute issue can influence some cardiometabolic related health concerns like raising your blood pressure or blood sugar. Next slide. There were over 4,000 cases with a diagnosis of gender dysphoria within PedsNet, and we matched them approximately 1 to 4 with the control group on 8 variables, some of which affect cardiometabolic health from a pool of nearly 200,000 youth without a diagnosis of gender dysphoria. And as I mentioned, these data are from electronic health records. So we have available to us information on a patient's age, sex, race, ethnicity, insurance status, and all of their medical visits at each site. And importantly, we also have access to their vital sign measurements, laboratory results, and diagnoses listed in their problem list, as well as those used for billing codes associated with a medical visit. Next slide. So what did we find? Let me first orient you to this figure. So the x-axis shows odds ratios, or the risk of having one of the outcomes listed on the y-axis. Black indicates individuals with gender dysphoria and a female sex listed in the chart, and red, those with a male sex listed in the chart. And the odds ratios are represented by dots, and the whiskers show their 95% confidence intervals. So if these whiskers stay completely to the right of one, there's a higher odds of having these diagnoses in those with gender dysphoria. And if completely to the left of one, there's a lower odds of having these diagnoses. When the whiskers cross one, the odds are not different between the two groups. So the diagnoses on the y-axis were captured either by having a diagnosis itself recorded in the medical record or by having abnormal laboratory values or anthropometric data like BMI and blood pressure readings. So as you can see, youth with a diagnosis of gender dysphoria have a higher odds of having high blood pressure, liver dysfunction, and dyslipidemia or abnormal cholesterol in both sexes. And when we look at PCOS or polycystic ovary syndrome and overweight and obesity, you can see that those with gender dysphoria in a female sex listed in the chart have a higher odds of having these conditions. Because all of the cases and controls with PCOS had a female sex listed in the chart, we're confident that the sex in the chart reflects their sex assigned at birth and not their gender identity. Next slide. So what do these data tell us? We found that in this large multi-center analysis, youth with a diagnosis of gender dysphoria have a higher odds of having diagnoses that are related to their cardiometabolic health than matched controls. And I do want to note that these preliminary data have some possible confounders, such as the fact that we know that some youth with gender dysphoria have higher rates of overweight and obesity, and that having overweight and obesity itself increases your risk of having these other diagnoses. We also know that youth with gender dysphoria have higher rates of mental health comorbidities, and we've also shown this in PedsNet, as well as getting less physical activity, and they also may be taking medications that could all influence their cardiometabolic health. So that said, our future analyses will consider these possible confounders, as well as look to see if there is or isn't a relationship with exposure to gender-affirming hormone therapy. Because just to reiterate, this analysis did not separate those who were exposed to estradiol or testosterone from those who were not. It defines a relationship specifically between a diagnosis of gender dysphoria in their medical record and the odds of having diagnoses like hypertension, liver dysfunction, cholesterol abnormalities, and so forth. Next slide. I'd just like to thank the rest of my team at Children's Colorado and the University of Colorado and our funders, which include the NIH Pediatric Endocrine Society and the Society for Adolescent Medicine and Health. And I'd be happy to answer any questions during the Q&A period.
Great, thank you so much, Dr. Valentine. Now I'm going to turn it over to our last speaker, Dr. Zhu.
Thank you for that introduction and to the Endocrine Society for the opportunity to share our results. I will be presenting our results from our study titled A Genetically Defined Male Counterpart of Polycystic Ovary Syndrome, Evidence for Ovarian Independent Pathogenesis. Next slide. We have no relevant disclosures. Next slide. I'll first summarize our key finding, then discuss the specifics of our study design and results. The take-home message is that men can develop characteristics of polycystic ovary syndrome, or PCOS, a common reproductive disorder that by definition affects only women. To show this, we took genetic factors that contribute to the risk for PCOS in women and examined them in men. We found that in men, these genetic risk factors for PCOS are associated with increased risk for obesity, type 2 diabetes, cardiovascular disease, and male pattern baldness. Because these PCOS genetic risk factors can increase the risk for these conditions in men who do not have ovaries, our findings show that some of the mechanisms leading to PCOS in women do not act primarily through the ovaries. Next, I'll review the background of PCOS. Polycystic ovary syndrome is a very common disorder affecting 6 to 10% of all reproductive age women. It is defined by the key features shown on the right of irregular menstrual periods or ovarian dysfunction, excessive hair growth or hyperandrogenism, with or without polycystic ovarian morphology on ultrasound. In addition to infertility, PCOS is associated with the often lifelong conditions of obesity, type 2 diabetes, and cardiovascular disease, all forms of cardiometabolic dysfunction that contribute significantly to the billions of dollars in estimated annual healthcare costs for the care of PCOS. We still don't completely understand what causes PCOS, and as a result, the current treatment options are limited to management of the symptoms without really addressing the underlying causes. Determining the different causes for PCOS is really the first step in identifying the potential treatment targets for the disorder. Next slide. There may be multiple causes or pathways to PCOS. For example, an inciting factor could cause ovarian dysfunction, which then leads to the hyperandrogenism and cardiometabolic dysfunction of PCOS. Next slide. Alternatively, an inciting factor could cause hyperandrogenism and/or cardiometabolic dysfunction as the initial manifestation, which then leads to the ovarian dysfunction of PCOS as a secondary consequence. Next slide. Or the ovarian and non-ovarian pathways may be parallel and independent as well as interrelated. And the given pathway or pathways to PCOS may be different in different people. We can really use genetics to further understand these causes and pathways. Next slide. In our study, we calculated a polygenic risk score, or PRS, as an estimate of an individual's genetic risk for PCOS. We did this in approximately 180,000 men in the UK Biobank, which is a population-based study in the United Kingdom. We subsequently assessed for associations between the PCOS genetic risk score and our outcomes. Again, because men don't have ovaries, this allows us to study the factors that exert their effects outside of or independent of the ovaries. Next slide. One example of an outcome we examined is obesity. We observed a 9% increase in the odds of obesity for every 1 standard deviation increase in the polygenic risk score, or the estimate of genetic risk for any one person. To illustrate this, we examined the odds of obesity in men with both a high and low polygenic risk score compared to the rest of the population, as shown on the right. And we found increasing odds of obesity across increasing genetic risk score percentile cutoffs, as depicted from the bottom to the top. For example, men with a risk score in the top centile had a 28% increase in the odds of obesity, whereas men with a risk score in the bottom centile had an 18% decrease in the odds of obesity. These results show that the genetic risk for PCOS manifests as an increased obesity in men. Next slide. We further assessed the relationship between additional outcomes and our polygenic risk score. We observed that hemoglobin A1C increased as our score increased, HDL cholesterol decreased as the score increased, and triglycerides increased as the score increased. For type 2 diabetes, coronary artery disease, and androgenic alopecia, or male pattern baldness, we observed an increase in the odds as the genetic risk score increased. Next slide. In conclusion, we showed that genetic risk factors for PCOS do not require ovaries to result in the cardiometabolic dysfunction and hyperandrogenism of PCOS. Thus, in some cases, PCOS may be caused by biological mechanisms common to both women and men. Future studies of our mechanisms will identify potential treatment targets of the metabolic dysregulation associated with PCOS for both men and women. Great, thank you for your attention. I'll take questions in the Q&A section.
Awesome. Thank you so much, Dr. Zhu. I'll now hand it over to my colleague, Jenny, and she'll begin the Q&A and read a few questions from our journalists. As a reminder, feel free to type your questions in the chat window.
Great. I have a question for Dr. Gregorian from Marie Benz at medicalresearch.com. She asks, how much does aldosterone screening cost? How often would it need to be repeated in high-risk patients?
Hi, thank you for your question. I can't tell you the exact amount, but I don't believe that it's very expensive. It's likely under $20, and it's a routine blood draw. Essentially, I think it should be repeated maybe once, at most twice, if the results were confounded, to kind of rule out the secondary cause of the hypertension.
Great, thank you. Great. I have a question for Dr. Valentine from Kristen Monaco with MedPage Today. She asks, do you have any thoughts on the mechanisms that underlie your findings? Do you think these cardiometabolic outcomes are likely tied to hormone therapy?
It's a really good question, and that's something we want to look into next as the next part of our analysis, to kind of separate out these youth with gender dysphoria and who's receiving gender affirming hormone therapy and who isn't, and if that changes their risk. We do know, as I presented the adult data, that there is some association with estradiol use and testosterone use with differences in cholesterol parameters, for instance. But it's something it's essentially still an emerging field in pediatrics. And like I said, we have some small single center studies that sometimes say, yes, with hormones, we see an increase in BMI, for instance, but then other studies say this actually looks very stable on this hormone. And so I think the fact that we have such a large cohort in this multi-center analysis for our next steps, it'll be really interesting to look at that.
Great, thank you. Great. For Dr. Mullaney, I was wondering what steps would be involved in getting this molecule to become an actual drug therapy that we could use in people?
Yes, so we have done some preclinical pharmacologic profiling of our drug in mice. However, a lot of cardiac studies go to larger animal models, and that's usually a pig model. And so we would do pharmacologic profiling in the pig, toxicity studies, dosing, and also we would just simply need to prepare a high quality preparation of our drug that meets the GMP criteria. And then after that, we would go into human clinical trials.
Great, thank you. I have a question for Dr. Zhu from Fabiano Stefati with Medscape. He asks, in your clinical practice, do you dose estradiol, estrone, dihydrotestosterone in men? Do you use any of them to aid diagnosis and treatment?
This question for me? Sorry.
Yes, exactly.
Oh, yeah, thank you for the question. I'm actually a practicing pediatric endocrinologist, so I do not clinically treat men. So I actually do not know the answer to that question.
Great. While I have you, I was curious, how do you think your findings change the way we view PCOS in women?
Right. Yeah. So I think our findings really highlight the fact that PCOS is much more than a condition of the female reproductive system. It really puts front the issues beyond infertility that really affect women in the reproductive years and kind of puts our glasses on what happens after the reproductive years. And so these are things like the cardiometabolic effects that we're seeing. So our study really provides kind of additional support for putting a focus on the lifelong complications of PCOS that affect both women as well as men with these genetic risk factors for PCOS.
Great, thank you. That's all the questions we have in our queue.
All right, great. Thank you so much, Jenny. So yeah, again, thank you so much to all of our speakers and all the journalists that joined today and took the time for this really interesting discussion. We really appreciate it. And as a reminder, the news conferences will be available on ENDO webcasting and our website and YouTube following the presentations today. If you have any questions at all, please feel free to reach out to media@endocrine.org. We're happy to set up an interview and help with anything you might need. So with that, thank you so much again for joining.